This is the Skin Science Podcast. I'm Dr. Thomas Hitchcock, and here we'll investigate everything skin science and dissect it from a scientific perspective, analyze it from a medical perspective, critique it from a consumer perspective, and give insight from an industry perspective. Hello, welcome to the podcast. Today I am alone in the studio with the Peanut Gallery as Angela McDonald could not make it today, but we have a very special guest, Dr. Amelia Hausauer. How are you, Amelia?
Good. I'm so excited to be with you all.
Yes, so I've been chatting for a couple of years at this point, I think, with Dr. Hausauer, and we've been trying to find ways to work together, and we are going to be working together. But she was kind enough to come onto the podcast to discuss today's topic, which is melasma. But let me give you a little bit of background on Dr. Hausauer. She's a board-certified dermatologist and from the Bay Area, earning a bachelor's degree of arts with the highest honors in human biology from Stanford University. Dr. Hausauer subsequently earned her medical doctorate at the University of California, San Francisco, and received multiple competitive scholarships. After completing internal medicine internship, she jumped into dermatology residency at NYU, which is somewhere I'm very familiar with. And then she did an ASDS fellowship in Los Angeles. So she went from West Coast to East Coast, back to West Coast. So she must be a West Coast gal. And she currently practices in aesthetic medicine and dermatology in Silicon Valley, California, where all those tech giants are. Thank you, Amelia, for joining us. Why did you move from West Coast to East Coast to West Coast, back to West Coast? Why didn't you stay East Coast?
I am a West Coast girl born and raised, and moved to be closer to family. I guess brought my husband here kicking and screaming because he's an East Coaster. Taken him 5 years to get adjusted.
Yeah. Well, I got to say, I have lived the South. I've lived in the Northeast. I've lived the Mid-Atlantic. I've lived in Texas. I've lived in the West Coast in San Diego. I have to say that other than the taxes, San Diego is by far my favorite. So I'm probably a West Coast person myself, although I'm right now in Dallas, Texas, which is by far nowhere near to West Coast culture. It's a
little different.
A little different, yeah. So I think I'm probably a West Coast person too in the inside, But anyway, we are talking today. Oh, before, I don't want to forget, we have in the Peanut Gallery, we have Dr. Jose Maldonado, and we have Alan, our director and producer, and then our co-producer, Seti, is back from her excursion across the ocean. Where were you, Seti?
I was in Germany for 2 weeks and in Japan for 2 weeks.
Okay. And so if anybody doesn't know Seti, she is half Japanese, half Persian, I believe, correct?
Yes, that's correct.
And so she teaches me all the things that I need to know about Japanese culture. And actually, that leads me to, I don't know, Amelia, if you know, but on the podcast, I always feature a puzzle. I'm a huge puzzle fan.
Yeah, I know you are.
Yeah, and so this is actually a Japanese puzzle. It's called a karakuri puzzle, and this is one of the new ones. It was one of the Christmas presents. So if you're on the club, they give you, you can sign up to get a different designer a Christmas present each year. And this one's called Regression Cube or something like that. I can't remember the name now. I haven't actually solved this one yet, so I brought this one today because it's pretty cool. And I always like it. The karakuri puzzles are cute usually, but they're very easy. And I really like them when they're harder. So this one's a little bit harder. So I haven't even solved this one yet. So that's today's puzzle. Anyway, we are talking about melasma today. But I'd like to open it up, to anything that's, dyspigmentation. But I think melasma is probably to our listeners going to be one of the more interesting ones, because we all kind of understand a lot of what drives certain dyspigmentation issues, but melasma is one of the more mysterious ones. It's one of the ones where we have a lot of people that do a lot of things, but we don't really understand what drives it completely. But there is some new science that we'll talk about that shows us a little bit about what might be driving it in addition to what we already know. So why don't you give us, from your clinical perspective, what do you do in your particular practice that is concerning melasma? Do you have a lot of people that come to you with this? And when you see them, what do you tell them as far as what causes it?
Right. So as you said, melasma is kind of this very fickle condition, right? It's something that we control, but we don't necessarily cure. And I do have a large, a sizable population that comes to me that has melasma. Maybe that's a relic of being on the coast where it's nice and sunny. And we'll talk a lot more about ultraviolet and sun exposure and how that might play into melasma. But for people to kind of conceptualize and to take a step back, this is the type of pigmentation, not where it's like a discrete little brown spot, but where it almost looks like a net often on the skin. So it looks more like muddy patches, or even, when people get pregnant, they can have something called a mask of pregnancy. So it can be very diffuse over the face. And when people come to me, I'm trying to just determine what type of pigmentation they might have, and if it falls under, sunspots, or if it's more in this category. And then we tackle it from a kind of a multifactorial way.
Right. And so I think that's one of the things that people are a little bit, what's the word? I don't want to say uneducated because that sounds really bad, but they're not as knowledgeable about is they think that all pigmentation is caused by the same issues that can be solved by the same things. And I think what you said was one of the things that people don't quite get, which is we don't yet know any cures to melasma. And so if you actually get on a therapy and then you stop the therapy, you shouldn't be upset if it comes back because there's an underlying issue involved that may not be curable. But is this something, I mean, do you have any insight, and this is something I don't know, but do you have any insight into historically, is melasma something that has always been around, or is it something like other inflammatory issues that tend to be more associated with Western culture because of sanitation issues, or is there, is it a...
I don't actually have I don't have a specific answer to that. I don't know. My guess is it's been around for, centuries, and it's more prevalent in certain populations. If you look at studies, those of us who are Asian or Hispanic tend to have a higher incidence of melasma. I do think that there is more inflammation of the skin. There's more breakdown of the skin's barrier that increases the likelihood of development of melasma. And so my guess is it's changed over time, even though we have seen it for a long period.
Right. So one of the things you'll find, if you don't already know this about me, which I think you do, is that I always bring it back to the skin biome and the microbiome.
Oh, yeah.
Because for me, I think it's one of the pieces of dermatology that has been a little bit overlooked as far as, what that does. If you think about that, you have microbes on your skin, and the way you treat them is going to influence how they treat you. So, they're spitting out stuff all the time. So if they have the wrong food source or the wrong environment, they might spit out stuff that can contribute to disease states, which melasma might be one of them. And so let's really quickly visit what we alluded to before. I think we alluded to this already, which is that there is a publication. Let's see, what year was this? It was 2022, so it was just last year in March. So it's about a year old at this point that it's been published. And the title is Sebocytes Contribute to Melasma Onset. And that was one that when I saw that, it actually really caught my eye because that ties it right into the microbiome in the way that the most prevalent microbes on the skin are Cutibacterium acnes, which is a lipophilic microbe which eats the sebum, turns into short chain fatty acids. And so disruption of when you don't have as many lipophilic microbes like Malassezia or C. acnes, that can actually contribute to an excessive oil or excessive sebum. And my thought is, well, maybe we just don't understand how that can affect melanogenesis. And one of the things that we do know is that propionic acid, which is a short chain fatty acid that is produced by some of these microbes, actually can reduce symptoms of melasma. So that's super interesting to me because in our study for a line of products that you're aware of called BioJuve that Crown makes, we actually saw a decrease in some of these signs of things like melasma and pigmentation. And we were like, why in the world were we seeing that? And then we realized, oh, well, we noticed that it was mattifying. So it's eating those oils. And if we know that sebocytes are involved in melanogenesis, maybe there's a tie there. I don't know. What do you think about that?
I think that's actually a really great point. And, initially we thought about melasma as a problem of just pigmentation. We're
Right.
over making pigment, right? And so it's just a melanocyte, the cells that make pigment. It's just a problem of that line of cells. What we now know is that it's a much larger microcosm, right? It is the interaction of the melanocytes with the keratinocytes, which are the majority of the epidermal skin cells, and even the fibroblasts and the vasculature and the sebocytes. So it's a much larger environment, and how that environment is interacting is going to ultimately impact the production and the transfer of that pigmentation.
Right. So it's, and not only that, but the microbes could possibly play a role as well, right? Because if they're all
Right.
connected in a way, I guess what you just said is a brilliant distinction between what medicine is doing now and what it used to do, which is like tyrosinase inhibitor equals no more melasma. But the thing is, you are not treating any of the underlying causes, which are inflammation and senescence and all sorts of things that come along with it. So you could be putting, and this is one of the reasons I left my postdoc in tissue engineering, went on to do other things, because tissue engineering also is that same thing, which is like you're putting a perfect tissue into a diseased state and then it becomes diseased again.
Right.
So it's
Yeah.
like, so I think that was a wonderful way of that you put it, as far as like, there's just so many, we're finding out that the body is so complicated, and now we're throwing in the microbes on top of all the human components. So
Right.
what is somebody to do? What is a dermatologist to do? There's so many things to consider now. So what do you do with what is, so let's, I guess, ask, what do we traditionally know of as treatments for the appearance of melasma, and what changes in your mind as a clinician now that you know it's probably more complicated?
It's much more complicated. And I think, traditional treatments and ways to manage melasma rely really heavily, and these are still very critical pieces of the puzzle, right? Rely really heavily on ultraviolet sun protection as a mitigator of one of the things that we know is a real trigger for melasma. So sun exposure, we're learning more about even visible light, like from computer screens
Mm-hmm.
and overhead lights, all of these environmental, those can trigger increased pigmentation. So really targeting that. And then the other big piece is lightening agents. So things like hydroquinone
Mm-hmm.
or combination agent that block the production of the pigment. So, right, if you're thinking about that whole little environment where ultimately you're making too much pigmentation, we're talking about the tail end here. We're blocking that tail end.
Right.
And so that's traditionally how we've tackled it. Now as a provider, I'm thinking about what might be all of the etiologies and the causes and the dysregulation upstream, and
Mm-hmm.
how are we going to affect those in addition to maybe working more immediately at the tail end.
Right.
Um,
And so, like, let's talk about some of those therapies that you've talked about, that, like, for instance, hydroquinone, a little bit of controversy around that. Could you shed some light on what the controversy is, and whether or not you feed into that controversy, or whether you think it's, or if you even want to comment?
yeah. I mean, so controversy, it's multifold.
Yeah.
Now, hydroquinone is banned in many, many other countries. There was a lot of concern initially with potential carcinogenesis, really hasn't panned out in studies. There's also the concern with using hydroquinone for long periods of time and getting something called ochronosis, which is a different type of pigmentation that occurs. So are you getting a rebound, or really the opposite effect that you're wanting? And so parsing out how to use hydroquinone effectively and safely can be a little bit difficult.
Right. Have you or others that you know of changed to other things other than hydroquinone because of the controversy? I know some people use arbutin because it's upstream of hydroquinone, and they feel that because the word hydroquinone is controversial, they can get away with it by doing that. What's your thought on that?
I think that's one strategy. I tend not to steer clear of it because I do feel like of all of those tyrosinase inhibitors that we have in a bottle, it tends to be the most effective. The problem is it is also very irritating. So there are a lot of people that don't tolerate it. So
Mm,
even if you get get around this controversy. A lot of patients get too irritated, too red. If you're causing too much irritation, then you run the risk of causing post-inflammatory hyperpigmentation, which is,
Another
now you're
thing.
shooting yourself in the foot, right? So it becomes a little bit tricky.
Right. Yeah. I think this is one of the things that and I'm happy if you can like shed some light on your opinion on this, but one of the things that I see in dermatological medicine is that there's lots of great molecules that have lots of science behind them. Things like hydroquinone, arbutin, vitamin C, retinoids, and they all have their place. The problem is our skin is made to keep things out, right? And so in order for us to get things in, we have to put them in relatively large doses, which when they hit their watershed, meaning like it's kind of like you put enough weight, it just all of a sudden floods in, and you end up a lot of times with these irritations. For instance, I just simply cannot tolerate retinoids, not even the cosmetic levels. It causes me to, not immediately, but over a day or two, I'll get ulcers even on my face. And so it's one of those things where it doesn't mean it's bad. It just means that how do we navigate this, especially for like, for instance, melasma, where somebody's desperate, they really want, to get rid of this, but things like retinoids, vitamin C, hydroquinone are all going to be irritating. I could see where it could cause quality of life issue and depression issues on people that just feel ugly because do they just have to wear makeup then? Or what's your solution at that point?
I mean, so with a lot of these products, what ends up happening, and there's actual data for just using topical steroids in melasma, is that we put something that counteracts the inflammation.
Right.
May not be the right answer, but it's an answer, right? It's like, well, if these are all irritating things and we can kind of combat the side effects with something else, is that going to allow you to tolerate it? Is that necessarily that is one way of addressing it. But I think to your point, if you can look back, kind of backstream, right? If you can go all the way back and think about the environment that might be producing that pigmentation, whether that's the microbes or the sebocytes or even the breakdown of the skin barrier and how that might contribute to the environment, then you can tackle that from a different perspective that might be less kind of overall detrimental or difficult to tolerate.
Right. Let's talk about the sebocyte involvement with, have you, because I know there are people that use retinoids to battle melasma as well. What's your take on that? Because I know there's this new device that basically ablates the sebocytes, and I'm kind of going to sit and watch and see where dermatology lands on this because I don't think it's a great idea, but there are certain applications like hyperplasia and stuff that my family has that I would love to get it for my hyperplasia. I just want to keep the rest of them, intact because I think you need those. But for melasma, is there a place that there's lots of tools in dermatology that when used correctly, I think are going to really help people. The problem is a lot of times we either over or underuse them, and so what's your thought on like sebaceous gland modulators like retinoids and lasers, that can ablate the sebaceous glands, and what's your take on that?
So I think there's two things. One, basically, as you said, it's like we throw every device we try on everything or every treatment. But you really have to distinguish between overproduction, underproduction, normal production, and then what do you want to target? Which group? Because those are all very different populations, right? Sebaceous hyperplasia is an example of an excessive growth or overproduction of oil that you might target very precisely. And that's different from somebody who has really mature skin where we know that sebocyte and oil production declines naturally on its own. And they're then combating, excessive dryness and all of these other things. And you may not want to get rid of all of their oil glands because eventually down the line that's going to lead to problems.
Right.
In people that have melasma where the sebocyte is potentially critical in the etiology of their entire, pigmentary condition, you really don't, I get concerned about getting rid of or over suppressing the point of retinoids, or one of the points of retinoids in melasma, is because they have a exfoliative effect and they change the way that the keratinocytes turn over. But doing that, you're also hitting other cell lines and you're affecting the way that those turn over.
Right.
And that may not be a desired effect.
Right. One of the things that I've learned over the years is that in some melasma cases, you can actually have weird pigmentation down in the dermis versus just in the normal area. And very interesting in our labs at Crown, because we do a lot of research in the way that microbes affect different cell types and such.
Yeah.
And we've found some interesting phenomena that when we submit different types of ferments from different bacteria to fibroblasts, we actually saw an upregulation of genes associated with melanogenesis, which you're like, but fibroblasts don't produce melanin.
Yeah.
But then you're like, wait a second, maybe they do in the wrong conditions or with the wrong microbes. And so it starts to put a light off in my head that maybe, like you were saying, it's more complicated. And some of the things that we need to do is, rather than turn off everything for our oil glands, is saying perhaps we curate the microbes and see whether or not that, and of course it's not going to be the same for everybody, because I think, why don't you tell us about, is there different ways in which melasma presents itself that might give you a clue that it might be a different etiology?
Right. So melasma can be somewhat broken up into different categories. So there is pigmentation that is in the upper part of the skin, the epidermis. You can have, so that's epidermal melasma. You can have dermal melasma, where the pigmentation falls down into the dermis, so it's deeper, or you can have pigmentation where it spans both.
Mm-hmm.
The deeper it is, the more difficult it is to treat. It's, we have tools, chemical peel, all these other things that can exfoliate the epidermis and maybe exfoliate some of that pigmentation. It is much harder to get and treat lower down. And the further wrinkle, and distinguishing those can be a little bit difficult and sometimes tricky to the naked eye. In a clinic, we can use different types of special black lights and other things to get a sense of where the pigment is sitting, and you may target those slightly differently. One of the wrinkles with some of the treatments is that, and one of the difficulties with melasma, and why it's important to distinguish it from sunspots, is that certain lasers or other treatments can actually make it rebound and worse. And part of that may be because you're actually puncturing the epidermal dermal junction and you're getting more pigment falling deeper down. And so you have to be somewhat careful, because if you're causing too much inflammation and too much disruption there, it can have a counterproductive effect.
Right. This is all kind of making me think about how I want to start to swab skin of melasma patients and see whether or not there are issues. Because also, if you're drilling holes in people's faces, that's also a place for infection to happen. That's not in the sebaceous glands. So it's actually an opportunity for things like staph to ingress. And the question is, these are some of the staph microbes are the ones we're seeing that fibroblast production of melasma. So, I'm now starting to wonder if we're just scratching the surface, as far as we know, like you said, that it's way more complicated than we originally thought. But now I think, are we needing to look further into the non-human factors that affect melasma? But you said it was Spanish and Asians that mostly are affected, and then it's pregnancy associated as well.
Pregnancy. I mean, and so I think some of the racial ethnic differences also have to do with the different amounts of pigment that we make, right? So some cells are more active or have larger, what we call melanosomes, which are the actual little enveloped packets that deliver the melanin, than others. And that's partly has to do with distribution of pigmentation across different cultures. And so I think that comes into play. And then pregnancy is another time where we can see a lot of pigment forming. Oral contraceptive pills, so birth control pills, again, high. So estrogen, whether that's in pregnancy or from birth control pills or from hormone replacement therapy, all predisposes to increased pigmentation and melasma. And so as you're speaking, I'm thinking, well, we should look at what the microbiome looks like in somebody on a birth control pill versus, right? Because we know that hormonal influences are huge in terms of the bacteria that lives on our skin.
And not just bacteria, the fungus as well. So like
Yeah,
now,
exactly.
yeah. So now I'm thinking about like Malassezia, and we do know that certain certain fungus actually cause production of azelaic acid, I believe, and they cause
Right,
the
exactly. So yeah, no, azelaic acid, yeah.
yeah. So is there an opposite phenomena where we have fungus that can do the opposite? I mean, really,
Correct.
has any? I need to look and see if anybody's investigated that, because that's a very interesting thing. Should we be using antifungals for
Right.
melasma? Because it's, one of the reasons I'm thinking through all this is because we recently talked about fungal acne, and how while we tend to call things acne vulgaris on the face, there have been case studies where people have had recalcitrant acne vulgaris, and when they used antifungals like nystatin orally, it goes away. And so you ask yourself, well, why is it? Because it didn't itch, it didn't, it was, we get it with truncal acne why that would work, but why is it with
Yeah.
what was? So my question is, in my head, are we misdiagnosing or making things more simple in our head about A equals B versus, because we're not thinking through, all
All
this
the
stuff.
yeah.
So, all right. So now we're going to have to get into a clinical study together and figure this out. But,
Yeah.
you know,
And now I'm thinking, okay, well, because right, the amount of fungus that's living on your skin and the certain colonies of bacteria, there's gonna be pressures to squeeze one
oh
or the
yeah,
other out. So it's also right the balance between those two and how, yeah,
100%. And even more interesting is that I've read publications. So a lot of people get scared with the word biofilm. They think it's a bad curse word in dermatology, but frankly, biofilms are how all microbes establish themselves on our bodies and in our gut. Biofilm actually protects the good ones so that they can keep us healthy. And so, but there's research that has been shown that fungus can actually commandeer bacterial biofilm. And so I'm wondering whether certain conditions, certain hormonal conditions, certain bacteria, certain strains of bacteria can contribute to this particular phenomena. And of course, we're just kind of spitballing ideas here. But, the reason why I think it's fascinating is because we're already observing certain things with the microbiota. Like we know that C. acnes actually produces something in its ferment that is antifungal. We know propionic acid. It has been
right.
shown that at 0.5% propionic acid in the ferment of C. acnes actually can reduce significantly fungal infection. And so there was a publication that just came out that it wasn't something we did, but it was something that we've observed in our clinic as well. And so
Oh,
I'm not. I mean, it's for me. This is all fascinating because I'm that person that my professors used to get mad at me because they're like, Thomas, you don't have to reinvent the wheel for everything. so I would, yeah. But sometimes it takes somebody to ask the question, are we doing things right?
And I think that I do think it's a really good point, because we're in a lot of the work that you guys have you looked at barrier function and how that changes with these microbes.
Mm-hmm.
We know in melasma, there are defects in barrier function and in, and in the interaction between the upper and the lower part of the skin, and even the blood vessel environment that is feeding the skin.
Mm-hmm.
And all of that is very intimately connected with the microbiome.
Right. So again, this is one reason why for me, as we progress in dermatology and medicine, skin science and medicine, it's very important that we start to think of the need for skin biome care versus just skin care, because it's one of those things where it's a eye rolly type of nuance, but it really is important because, just like you're alluding to, when things are complicated, you have to assess all possibilities, not just, oh, it must be a human genetic or a human issue solely, because what lives in and on our skin that's not human is affected by the things that we produce. So really quickly, let's, what were we looking like for time? 30 of. Okay, so we got about 10 more minutes, I think.
Yeah.
All right, and so let's move on to the nuance of genetics as far as gender. Tell me why you think, I can tell you what I think, but I want to hear what you think about why females are affected more than males. And is it like a similar phenomena to why females tend to get cellulite more than males, you know?
Yes, I think I do think that that is actually a really great comparison. So as we mentioned, the estrogen environment, right, can predispose to melasma, and the estrogen to testosterone and other hormonal balance in men versus women is very different. There's actually some interesting work where they look at men who have prostate cancer who are on therapy to block testosterone. Their incidence of melasma goes up, right? Because that relative balance and change in hormonal environment is very different. And so that is I think one of the big reasons that that it's more common in women than men.
Okay, so hold on, you just raised something that I'm curious to ask. You said if they block testosterone, it's more prevalent to melasma. So is estrogen a byproduct of testosterone, or is it made independently as well?
It's made
Okay.
independently.
All right. So
But
basically it's basically when you don't make the testosterone, you're only making estrogen, and therefore okay.
yes.
All
So
right.
I think that there's two things. Increase in estrogen actually can change gene expression that is integral into the pathway of pigment production,
Mm-hmm.
and so that's one thing. And then there's also the relative balance of estrogen and testosterone that can have an impact on a lot of different skin environments.
Interesting. And so that makes me ask the question, are you familiar with androgen insensitivity syndrome?
Yes.
Do you know any prevalence stats for people with, I know that's not a hugely prevalent state, but I wonder if they get melasma and whether or not there's an issue with them.
Uh, I don't know of any direct studies that look at the incidence but it would be a really interesting population to look at,
It
right?
would, right? Because
They-
the reason I ask is because there's populations that we find things like, for instance, finasteride was found through that pseudohermaphroditic population. And so I'm wondering whether if we could study some of these unique syndromes that might shed some light on this.
yeah, no, I think it would be a really interesting population to look at. And I should tap some of my patients who do all this AI and have them then call through a bunch of, right? Like
Yes.
what might be different in, yeah,
That might be the next unicorn company. I mean, I need to
exactly.
get stock in that because I thought it up. So, all right. So let's talk about, because we talked a little about treatments for melasma traditionally, and
Mhm.
we touched on some about what you do now. But what is kind of like if I have melasma and I come into your practice, what do you do? What do you give me? What should the consumers, the non-physicians that are listening to this, what should they take away? Should they try at home to do it themselves? Is there something they can do themselves? Or is it, I need to go see my dermatologist? And what is my dermatologist going to do that's going to help me?
Right. So great question. So first and foremost is being very proactive about ultraviolet sun protection. We talk about broad spectrum sunscreen, so things that block UVA and UVB. Zinc and titanium are two of the more common sunscreen ingredients that will be effective. The other piece that can be critical for melasma patients, because we know more and more there are publications looking at visible light and even infrared spectrum, so heat type light,
Mm-hmm.
is blocking those. And though, in particular, visible light is often blocked by iron oxide, which is what gives sunscreen their tint.
Right.
So tinted sunscreen can be helpful in melasma patients more so than in others.
Wait a second. You're saying that the iron oxide that's found in makeup
Yep.
and tinted sunscreens actually
Yeah.
it helps absorb the infrared,
It helps absorb the visible light.
the visible. Okay.
Infrared tends to be best blocked by, at this point at least, antioxidants of various sorts. So
Okay.
there are antioxidants that can be put into sunscreens to help with infrared. And then there are antioxidants that are made by microbes or that we put on our skin, right?
Yes, there are.
Those can be
I love
helpful
that
as
you
well.
just plugged that. um, No, let me ask you this about the sunscreen thing, though, because we talked about some controversies, and I would like to
Yeah,
hear it from a dermatologist because I hear different opinions from different dermatologists, and I want to hear your opinion on this.
yeah.
Chemical or physical sunscreen, and why?
I personally like physical sunscreens because I think, you know, I think there are two reasons that people will talk about chemical versus physical. One is there's this idea that physicals, you know, they will block and reflect the sun, and others absorb sun, and you'll actually get heat into the skin. That's really probably, if you talk to a lot of chemists, that's not true. They all have the same
Yeah,
effect in terms of absorption or reflection of
yeah.
sun.
I've had that
The
debate many times, and
yeah,
people don't like to. I don't. It's not really something you got to die on the sword for, but I think you're absolutely correct.
yeah,
It's all absorption. So,
correct. The For me, physical blockers tend to be less irritating.
okay,
So for some people that have sensitivity to, oxybenzone is the most common thing that will cause sensitivities to sunscreen. And especially in a population like melasma where they already have really sensitive skin, that any inflammation might increase pigmentation production. I want something that's going to be as inert as possible.
right.
And so I tend to like physical blockers for that reason.
Yeah, I think, more and more I'm hearing the physician based, the dermatology physician based, lean towards physical. The only problem is physical sunscreens tend to be very whitening cast, and for darker skin types,
Yes.
they tend to shy away and go more towards chemicals. Even the tinted ones sometimes are just they don't match their skin tone. So, what do you typically suggest for your darker skin types?
So, right. So even the tinted ones in certain skin tones can be like graying almost. It's like you
Mm-hmm.
get look ashy.
Yeah.
And so I am like, there's no universe. First of all, there's no universal tint. I'm
Right.
sorry. That's
There
just
isn't.
not, it's impossible.
Yeah.
I don't work the same as my partner who is African American. It just doesn't work. Um, so I often will have people either blend sunscreens because at least they're getting a sufficient quantity.
Right.
So like 2 fingers worth is what you want on your face, or layer with makeup, right?
Mm-hmm.
So if you find one that you think is mattifying that you like as a primer, and then you can put makeup over the top of that, then you're getting that added boost of the iron oxide. You're getting
Right.
more protection from the visible light, and so that can be helpful.
Yeah, so because men are not as affected by melasma, women tend to wear makeup more often than men, although in
Correct.
today's world that's not always the case, but more often I'd
I'm sure.
say as a rule. And
Yeah.
so I would say it makes it a nice kind of reason why you don't need to worry so much about that white cast if you're going to wear a base on
Yeah.
top of it. Actually, Angela, who's not here today, she told me yesterday that one of the things that she's been doing is mixing her base with the sunscreen. One of the sunscreens is in the Biojuve line, and she said it because she used to love this Tom Ford product that was a tinted sunscreen, and they stopped making it, and so she said it basically is better than the Tom Ford thing when she mixes it. And I was like, hey, get creative.
Go for it.
Yeah.
Yeah.
So anyway,
And that's part of it with sunscreen. I do think you have to be willing to play around a little bit and figure out and I know that can be off-putting for a lot of people, right? Because it's like the texture
right.
but there are so many more elegantly formulated sunscreens now, that it is easier to find one that you think is like tolerable.
Yeah, it's just there's just so much noise out there about what's
Yes.
killing the reefs and what's killing you, and
Yes.
it's just very difficult. And so that's where the dermatologists really come in, and even in the dermatology community, there's a lot of noise
Yeah.
because there's different people that have their own brands, and so it becomes very. I think sunscreens SPF is one of the hardest things to find one for that's right for you, and a lot of people get discouraged and just don't wear it because, for them, it's like, I don't even know what's what anymore. So I just don't wear sunscreen.
Right.
So,
Right. Exactly.
yeah. And so I think for women who have melasma, that's a very big message to them that if this is one of the biggest ways to actually mitigate it, even though you can't treat the disease state at a low cost, you're saying that you say, let's go for the physical first. If you need to match your skin tone, try to mix your base with it, but do wear sunscreen. That's probably number one, what you would suggest from what I'm hearing.
And one of the really interesting things, and I think this was like a little impromptu experiment, when people started working from home and sheltering in place more with COVID, I had a whole bunch of patients that came in and they said, I don't understand why my pigmentation is getting worse. I'm not going out as much. And I was like, well, are you using your sunscreen while you're working next to your window at home? And they were like, no, I'm inside. I was like, well, UVA comes through glass. So for people that have melasma, they have to be using it really diligently, whether you're indoors or outdoors. And that can be very difficult.
Yeah, I think that's just a lack of people knowing how UV works. And, additionally, there's UV that comes out of some light sources as well. If you've ever worked in the lab and you've taken a sticker off of a 5-year-old piece of machinery, you're like, why is this white and that's yellow? Because of UV. But I do think we need to wrap up soon. Okay, so I just want to ask, is there any other treatments other than sunscreen that you say they should look for?
So, I mean, there's a lot of different treatments for melasma. One thing that I think is newer that's interesting is tranexamic acid.
Okay.
Tranexamic acid is used in topicals, so in skincare, although it is tricky as a skincare ingredient because it's not very stable. And sometimes you need high percentages to get good efficacy, but those percentages don't sit well on a shelf. And so that can be a little bit difficult. It has been studied as like people will inject it. And then we are now using it more and more orally in select populations.
Right.
So this is a pill that actually was, traditionally is used to stop bleeding in an obstetrics setting. So somebody has excessive bleeding after delivering a baby, but because it works on a molecule called plasminogen and plasmin, it can have an effect on the vasculature and that whole environment we were talking about that may affect the melanocyte and the melanin production. And so we will actually use it as an oral pill for short periods of time in melasma populations. And that's something that's really within the last couple of years we've started doing.
Okay. So everybody, if you have melasma, ask your doctor about tranexamic acid, and there's probably different ways in which you can introduce it, and we won't get into that for lack of time. But Dr. Hausauer, thank you so much for joining me today. It's always a pleasure to speak to you. If the community that's listening would like to find you on social media, where should they look?
Yeah, well, thank you so much for having me. I am primarily on Instagram at Dr. Hausauer, so DR and my last name. And then our website is aesthetics.com, and that's AESTHETX, like aesthetic and treatment in one.
Yeah, and so if you're in the Silicon Valley, you should look for her, and she's probably in demand with all those media moguls, but you might be able to squeeze in there if you're lucky. All right, thanks, Dr. Hausauer. Thank you, Amelia, and I will be in touch with you, hopefully in the not too distant future. And oh, sorry, go ahead.
Oh, yeah, I will.
All right. Well, thank you, everybody, for listening or watching. We hope that you were able to glean something from this conversation. If you want to find more about us, please visit www.crownlaboratories.com, or you can follow me personally at Instagram at dr.t.hitchcock. And we will see you next time. Goodbye for now.